Good afternoon, everyone. Thank you for joining us today for our educational info webinar on the management of myeloma side effects and supportive care. I am Gabriele Colacerdo, the Manager of Education and Patient Services at Myeloma Canada. And today we have Teresa Miceli, who is bone marrow transplant nurse coordinator at the Mayo Clinic in Rochester, Minnesota, as well as Nurse Leadership Board Delegate at the International Myeloma Foundation, who will be presenting to us. Before we get to the presentation and Teresa, I just wanted to go over a few things with you. So without the support of our sponsors, our industry partners, these webinars would not be possible. So thank you to Amgen, Binding Site, BMS, Celgene, Janssen, Sanofi, and Takeda for helping make this possible. For those of you who have been tuning in to our weekly webinars, you're already aware that here at Myeloma Canada, we're all working from home. All of our events that were in person have either been postponed or will be adapted to an online format, just like this one over here. So today's presentation is actually a presentation that was supposed to be offered as part of our national conference, and we don't want you to miss out on the information. So we brought it to you virtually. If you don't already know, we have some virtual support groups on Facebook that you can find through our website if you want to join those. And also, if you're already part of a support group, we've provided the technology to all of our support group leaders to be able to hold support group meetings online. Next, right before we start, just to give you a reminder that all these webinars are recorded. We post them on our YouTube channel that you can access through YouTube or from our website. So I'll show you how to do that on YouTube, youtube.com. If you type in Myeloma Canada, the first link that you see here is Myeloma Canada. If you click on there, it'll bring you to our page. You can also subscribe to our channel. If you subscribe to our channel, every time we upload a new video, you will get a notification. That way you can stay up to date with the latest presentations. From our website, myeloma.ca, if you click on the menu bar at the top, click on resources, and then the drop-down menu will come down. You click on educational videos, that'll bring you to our YouTube channel where you'll be able to see all of those videos. So how do we ask questions? So on your GoToWebinar panel here, you have a little tab that says questions. If you click on the little arrow right here, it'll open up, and you can type in your question right here in this box and press send to send the question to me. I'll be receiving the questions, and I will be asking them to our presenter Teresa as we go. Today's presentation will be a little bit different than our usual types of presentation. We're going to be following a Jeopardy style format. So we'll have categories. So during the presentation, if you want to send in which categories you want us to go with next, or if you want to send some answers in there, I'll be happy to relay those to Teresa as we go through. So please do use the function as we go, and don't wait till the end to post all the information that you'd like to share with us. So without further ado, Teresa, thank you so much for joining us here today. We really appreciate it.
And thank you so much, Gabriela and Myeloma Canada, for including me in this, in what should have been the 15th National Conference, but unfortunately due to COVID, we are doing this remotely. I'm just thankful that we have innovation and electronics that we're able to meet virtually. So thank you so much for having me here. And I am a BMT nurse coordinator at Mayo Clinic in Rochester and a member of the International Myeloma Foundation's Nurse Leadership Board. But I come to you today on behalf of Myeloma Canada. And again, thank you for continuing to include me in these annual meetings. I so enjoy being connected with our myeloma, Canadian myeloma partners. Over the next hour, we're going to cover general topics related to myeloma. I thought it was fitting to do a Jeopardy format in honor of our shared celebrity, Alex Trebek. And with Gabriel's help, as he said, we are going to be hopefully making this fairly interactive. Questions and responses are encouraged. But please do note that even if you get an answer right, there will be no financial payout. I apologize, but I've got plenty of attaboys and well dones for you for those of you who get those answers right. And as I was also sharing with Gabrielle before we got on the meeting, is I have taken sort of maybe a foolish initiative and cut my own hair since I can't get into my hairdresser. So I'm really glad that you're showing this picture rather than doing the video webcast together. So let's get started and let's have some fun. All right, do we have, oh, it took over on its own. Do we have anybody that has an immediate question, or should I just start out with our first Myeloma 101, $200? We have 5 categories. Go ahead, Gabrielle.
Yeah, so we haven't received anything yet, but yes, I think to start off, it'll be best to start with Myeloma 101 for $200. And I do have one question that comes in. Maybe we could move to side effects later.
Okay, all right. And so we have the 5 different categories, and I have them arranged in a little bit of an order, but I'm happy to go out of order as people have interest in participating. So let's first start out with Myeloma 101 for $200. And the answer is, these non-malignant disease states precede active myeloma. And many of you may already be familiar with monoclonal gammopathy of undetermined significance and smoldering myeloma. These are what are considered to be pre-malignant states preceding that of active myeloma. And there's some definition that go to both of these disease entities or states of being that are more of an observatory state of diagnosis, where there are the presence of these clonal plasma cells, but no myeloma defining events. And for the majority of these people, we would say that we would observe and watch for any changes in that status or that monoclonal state before moving on to any therapy. For people with an MGUS, which is much easier to say, they have a less than 1% chance per year of evolving into an active disease state. There are some people with smoldering myeloma who are considered to be high risk, and those people we would observe more closely. And there's even a group of those patients that may be considered for treatment under a clinical trial. But it is these precursor states precede active myeloma. Now, not everybody will evolve into active myeloma who have a monoclonal gammopathy of undetermined significance. However, everybody with active myeloma has had the preceding or the precursor pre-malignant disease. And, oh, it went on ahead of me. So I'm sorry, there's a bit of a delay in there. All right. So unless there's a question or a category, we'll go on to Myeloma 101 for $400. And that answer is, these are the weeds in the garden. So what are plasma cells? Multiple myeloma is a blood cancer originating from the bone marrow and more specifically from plasma cells. We all have healthy, normal plasma cells within our bone marrow, and these are there to help protect us from infection. They help us fight infection through what are called immunoglobulins. And there are 5 different types of these. There's a G, A, M, D, and E. Now, for reasons not fully understood, this paraprotein evolves into a clone or a malignant state and reproduces the immunoglobulins sort of like a photocopier gone bad, replicating again and again, really not serving any purpose like helping us to fight infection. And I always think of this myeloma clone as sort of a weed within this healthy, rich bone marrow garden. This rich bone marrow garden normally produces things like your red blood cells, your white blood cells, and your platelets, all having a specific function. But when this weed or this clone starts to develop, it can cause significant damage throughout the body. And we'll talk about that more later in other categories. But for the majority of people, the overwhelming diagnosis is that of an IgG subtype of myeloma, where the immunoglobulin G is overproducing. And this is what is referred to as a heavy chain in the immunoglobulin. IgA is also a little bit more common as compared to those people with an IgD, an IgE, or an IgM. And there's even a smaller group of people who have what is referred to as a non-secretory myeloma, where they actually don't express any heavy chain, but we can tell from the bone marrow space that there's an overproduction of these clones. So Myeloma 101 for $600. And the answer is, he ain't heavy. And I won't sing, I promise. There isn't enough composine to have me sing for you guys to survive it. But the answer is, what are free light chains? So in the previous slide, we talked about the heavy chains, the immunoglobulin G, A, E, D, and M. Well, if you look at the actual structure of the immunoglobulin, you have this heavy chain component, and you also have bound to it this light chain component. And there are two of these. There's a kappa and there is a lambda version of these. Now, for some people, they have what is referred to as light chain only disease, where they're not overexpressing or replicating this heavy chain component, but only this light chain component. No longer is it bound to the heavy chain. It is freely circulating, and this can be measured in what's called a free light chain assay. For these people, oftentimes we see that there's a lot of renal dysfunction involved. This is what is known as Benz-Jones protein, where these small fragments are now infiltrating into the kidneys and causing renal dysfunction or kidney dysfunction. We also see these people having a large number of bone lesions, and we can see the calcium levels rise for these people as well. So that's another subtype of myeloma, is a monoclonal kappa or lambda free light chain subtype. So then if we don't have if we don't have people gearing up questions, I'll just move on to the $800 month.
Yeah. Teresa, we'll finish up this category, and then I have, I think, 2 or 3 questions related to this category that I can ask you, if that's okay.
Excellent. So this crustacean gives its name to diagnostic criteria. I bet you there are a lot of people who could answer this one. What is CRAB? Well, CRAB is the acronym that is used to define active myeloma. And historically, it was limited to just that of CRAB, which is high calcium levels, renal complications, anemia, and bone disease. But in 2014, Dr. Vincent Raj Kumar, who's at Mayo Clinic, along with the International Myeloma Working Group, came up with a new definition for active myeloma that included what are known as myeloma defining events. And this had to do with the idea of wanting to diagnose myeloma before complications were experienced. The idea of trying to get to the diagnosis and treat it well before people were having bone disease or renal complications. And part of the reason that we were able to come to this state of redefining myeloma is due to the treatment options that have become available. Historically, prior to probably 2005, the treatment options that we had were not as great as they are now, and sometimes had more toxicity than if we were treating somebody before they actually had the CRAB criteria. But now the definition includes these myeloma defining events, which includes having bone marrow plasma cells greater than 60%, free light chain ratio, where you're looking at the kappa to lambda ratio being greater than 100, and by MRI, looking for focal bone lesions, more than one greater than 5 millimeters in size, that would indicate that these people are likely to progress into active myeloma with these CRAB criteria within 2 years, therefore wanting to intervene early. Dr. Joe McHale has, who is part of the International Myeloma Foundation, he has coined the phrase slim CRAB. I'm not sure if it's fully adopted, but it sure does add to this CRAB criteria. And so, Gabrielle, you said that there were questions?
Yeah, so for this category, we talked about the plasma cells, and one person wants to know, how does myeloma cause bone weakness or compression fractures, or so how does it affect your bones? How does that work?
Okay, so there are different cytokines that the myeloma cell releases. IL-6 is very much implicated in this, and there's actually quite a lengthy pathway for which bone lesions are happen within myeloma. And we see about 80 to 90% of people who do have some degree of bone involvement. And actually, about 60% of people are diagnosed because they have a pathologic fracture that causes them pain and sends them into the doctor to be evaluated. When I think of it in simplest terms, I think back to this idea of the weeds. And if you can imagine weeds that are growing that are now getting into the cement foundation of your house and how that can actually cause cracking within that foundation, that's how I visualize the myeloma bone involvement. I know that's not a highly medical or technical way, but I think it's a good visual to think about in how myeloma, the myeloma clone begins to infiltrate within the bones, and there can be thinning of the bones where we can actually see this lytic or Swiss cheese look-like appearance on an X-ray or an image, but getting more extensively where the bone is eroded even more can actually cause a fracture. Most common bones that are involved with this process are the spine, the vertebrae of the spine, and the long and flat bones like the ribs, the skull, the arms, and the legs.
Okay, thank you. One more question for this category. We talked about the precursor conditions, MGUS and smoldering myeloma. So right before someone gets myeloma, they have these conditions. Now, at least in Canada, we don't, there's no routine testing for MGUS. I'm not sure if it's the same in the States or not. And if not, what's the outlook for the future? Is this something that we'll be testing for in the future, whether in Canada or in the US?
I think that's an excellent question. And for many people, this has come up at my support groups and other meetings that I've been at. And right now, there is not, even in the US, a routine testing for the blood disorders. However, Dr. Irene Gabriel at Dana-Farber Institute is working in conjunction with Mayo Clinic, Johns Hopkins, I believe also Seattle Cancer Care, Fred Hutchinson, a number of major institutions with the PROMISE study. And I'll give you a website on that in a future slide. But the PROMISE study is really trying to look at answering that question of how many people may have this MGUS, and should we be more routinely testing it. So they're starting with the African American population, which has a higher risk or rate of multiple myeloma, as well as first degree relatives of people with myeloma and lymphoma ages 45 to 75. And so I think it's an important question that in the future there may be more routine testing, but right now we do not have that either.
Fantastic, thank you. So I have more questions, mostly related to bone disease and bisphosphonates. So maybe we can cover those a bit later when we get into the supportive care treatments.
Absolutely. Now I'm hoping all of my slides advance as they should. It looks like they are right now. So we have category numbers and test results, treatments and transplants, symptoms and side effects, and living well. And I'll continue unless I have somebody who jumps in and says they've got a particular category and dollar value they want to work with.
So we did get a question about blood results and numbers, and how can blood tests tell you that you have myeloma. So maybe we can go into the numbers and test results, or how the myeloma affects your numbers.
All right, so we'll start from the top for $200. So age, the answer is age. The question is, what is the #1 risk factor for developing myeloma? And this is a question that comes up quite frequently, especially in my support group or any other meetings that I participate in, is why do I have myeloma? And quite honestly, the #1 risk factor is that we live long enough to develop multiple myeloma. As you can see, 86% of the people over the age of 55, that is the demographic that it falls into. And then that group actually is greater as we get even above 65, with the average or median age being 69 years of age. We do know that people who have this MGUS or monoclonal gammopathy are at greater risk of developing into an active myeloma. There is question about environmental contaminants, and the US government has recognized that our Vietnam vets who were exposed to Agent Orange, that they get supplementation based on that exposure. And this is where I was mentioning the PROMISE study, promisestudy.org, looking at family clusters. Is there a greater chance of having myeloma if you have a family member? We do know that African Americans are at least twice as at risk of developing myeloma compared to Caucasians, and even at a younger age. Interestingly enough, African Americans, if they receive proper treatment, can actually do better than Caucasians with the treatment and prognosis of myeloma. Men are more common than women to experience this, but it really does represent a very small number of cancers. When you think of things like lung cancer, breast cancer, prostate, or colon, myeloma pales in comparison for the percentage or volume of cases or the incidence, but is the second most common blood cancer after lymphoma.
So Teresa, we do have a question related to that slide. And it has to do with the timeline when it comes, from MGUS to myeloma. Is there like a specific timeline? Like we know that someone with MGUS within 10 years, for example, they will get myeloma, or is it more like 5 years? Or can you just elaborate a little bit on the progression and how long something like that might take?
Sure. So for MGUS, there's a 1% chance per year. So over a 30-year period, that evolves into, as you get older, maybe at the age of 90, you have a 30% chance of evolving. For the smoldering myeloma, there is that first 5-year period where people are at greatest risk of advancing to active myeloma. But after the first 5 years, the curves kind of settle out and show that then we kind of get more into that 1% per year risk of evolving.
Fantastic. So I guess we could just move on with this category.
Okay. So I believe we're up to $400. And this is going to answer, I think, some of the questions that people had posted. Poke, prod, and pronounce is the question, or is the answer. And the question is, what is the diagnostic workup for myeloma? And for those of you who have been evaluated, you kind of have an understanding of what this poke, prod, and pronounce is all about. There's a lot of testing that goes into establishing a diagnosis of myeloma, from blood testing to urine, that bone marrow biopsy, which everybody loves, and then imaging. And there's some key things that we're looking at when evaluating all of these results. Of course, the CBC is a reflection of what's going on within the bone marrow as far as the hemoglobin, the white cells, and the platelets. And we know that if there's an overcrowding of these monoclonal proteins within the bone marrow, the rest of those healthy cells, or I think of if there's an overcrowding or encroachment of weeds, the rest of the healthy growth of that garden is going to be depleted. And so we can see people experiencing anemia or low platelet count, and that's where that crab criteria comes in, that anemia. We're also looking at things like albumin, which is part of the staging system. We're looking at creatinine, which is a measure of your kidney function, that R for crab criteria, and calcium levels, which can also, which is also part of the crab criteria, that hypercalcemia, and that can be an indicator of how much bone resorption is happening or how much bone involvement there is. Also part of the diagnostic criteria or staging criteria is the beta-2 microglobulin. Then we get into, and these are relatively routine tests that can happen at any clinic or any lab, but then we're getting into more specific myeloma-related studies, monoclonal protein studies, both in the blood or in the serum and in the urine. And this is where the free light chain comes in, the immunoglobulin measurements, and something called serum immunofixation, which is sort of a very sensitive test to show where that protein lies. Some of you may be familiar with your M spike or your immunoglobulin level. And so these are important numbers to be following. We can also test the urine to see if somebody has this monoclonal protein in their urine, or that Benz-Jones protein that I had mentioned earlier. The bone marrow aspirate and biopsy are really important for a few things. One, we're really getting into that garden, into that bone marrow space, and seeing what the concentration of plasma cells are in that space. We also know that we can look at how fast these cells are growing. And now the plasma cell labeling index is not a routine test at all institutions, although we do it at Mayo Clinic. And it does give us an idea of, is this a creeping Charlie fast growing type cell, or is this more of a latent dormant type activity going on? So it's what we refer to as the labeling index, or how fast it's proliferating. We're also doing our genetic testing from the bone marrow to really give us some idea, do we have what is thought of as standard risk versus a high risk component in myeloma? And the FISH test is important to understand. Is there a high risk component that may direct treatment depending on how your provider is approaching your myeloma? This is also a test that can be done when we think of somebody who's already undergone treatment and looking, have they responded, and minimal residual disease and things of that nature. And of course, for imaging, there are a variety of imaging options available. The skeletal survey has been sort of the gold standard for many, many years. However, we know that it is probably the least sensitive of our imaging options. Many people like to go with the whole body low dose CT scan or PET scan, MRI. These are all options depending on what your provider would be recommending, and also coverage for those imaging techniques. Any questions on that diagnostic workup? I know there had been a previous question. Is that covered it?
Not with regards to the bone marrow tests, but I do have one with regards to lab tests, and for example, M protein. And so one person is asking, how low can the M protein drop after treatment? After, does it drop to zero for everyone? Does it stay stable? How can you comment on M protein and its the numbers you get after treatment?
It's an excellent question, and that is going to be a different answer for each person. Now, the M spike, the monoclonal spike, or what people know as the M spike, is really a measure of the heavy chain. If I were to show you a graphic of a serum protein electrophoresis, which gives you that M spike, you would see an initial spike, which is albumin, a very healthy, common protein in our bloodstream, and we want to see it there. And then we would see sort of this wave of mini spikes going on, which again is representing the healthy parts of our bone marrow or of our bloodstream, and the protein components like the healthy IgG, AM, all of these. But when there is an overproduction of that one protein, like an IgG, you are going to see a spike. And that spike is what is referred to as a monoclonal spike. Now, for some people who only have light chain disease or maybe non-secretory, they won't have a spike at all. And so that is not the number that would be monitored with their test results. That would not in any way represent their degree of response to treatment. But for people who do have that spike, and you really only want to compare your spike to yourself, not to somebody else. There can be somebody who has a monoclonal spike of 1.2 at diagnosis, and they go down, or maybe an M spike of 5 when they're diagnosed, and they go down to 1.2, and that shows that they've had a very significant response. And if they go up to 1.5, there's not much of a change there. But if you have somebody who starts out at 1.2 and they only go down to 1.1, you can tell that they've not had a huge response. So it is that M spike that helps to guide, but only if you have a heavy chain component of your myeloma, which is why it's really helpful to understand your specific subtype. I'm hopeful that I answered your question in a way that you can understand. Feel free to post another one if you'd like more information, or we'll just continue as we continue on.
Yeah, so we did get, as we were waiting, we did get information, question on bone marrow biopsy, and I'm sure you get this question pretty often. And are there any ways that we can get the information that we get from bone marrow biopsy, but without actually doing a bone marrow biopsy?
Well, there is a lot of conversation about doing a liquid biopsy, but there is nothing right now in place. And at the time of diagnosis, and any point where there may be a change up in treatment, getting a bone marrow biopsy can be really informative. I will tell you that at Mayo Clinic, knowing how uncomfortable these procedures are, that we really do look at doing these as sedated procedures. Not everybody is able to do that or has that as an option. We also have a team of people that this is all they do. So even though even though it's uncomfortable, they're really quite talented at doing it and relatively pain-free. But that it's another procedure, and fully understand why people would want another way of looking at the bone marrow microenvironment. But right now, this is our best option.
Awesome, thank you. We did get one more question right now at the end with regards to light chains and heavy chains, and just basically asking, they're clearly two different types of chains, but how do light chains cause certain consequences that heavy chains will not cause, or vice versa? So how exactly do each of those, how can each of those affect the body differently?
All right, and that's a good question. We talked a little bit about that on category 1, but those light chains, and again, there are two different subtypes, kappa or lambda, and they are smaller fragments. They are able to circulate and get into the kidneys, and this is where we do see more people with this kidney or renal dysfunction. And people who have a lot of protein in their urine may notice this, and retrospectively may recognize that they had protein in the urine by the amount of foam that they see in the toilet after they have urinated, that there can be bubbles even to the degree of having like a head of beer in the toilet. Those are our proteins, or Bence-Jones proteins, and that is, of course, not our most concise way of measuring, but it can be an indicator when people are looking in the toilet and saying, oh gosh, my urine is really foamy, very bubbly, that would be worthwhile having that further evaluated. The lambda light chain has been associated with a higher risk or more challenging to treat type of myeloma. But I'll tell you, myeloma doesn't actually read the textbooks, and so you may have a standard risk IgG kappa myeloma, which would be considered to be a standard risk or lower risk type myeloma, but it could be a bad player versus an IgA lambda, which may have higher risk potential, but is very easy to treat or well to manage. So it's really about how each individual's myeloma responds and reacts.
Awesome. Thank you.
All right. So it seemed to go directly into my next category within numbers and tests. And so we'll just flow with it. So the answer is right way and wrong way. What is the direction the numbers are going? And this is really having to do with measuring response, measuring disease response. And the International Myeloma Working Group has developed what are called response criteria. And I simply think of this as the myeloma cells and the proteins go down, we know that people are having a better response. And they've categorized a of what is called a very good, which means people have had at least a 90% reduction in their myeloma protein. So again, back to that idea of if you have an M spike of 5 at time of diagnosis, to get to that very good partial response, you want that to be less than 0.5. People can have a partial response, which is at least 50% of reduction, so that would say maybe 2.5, or minimal response or stable disease. Now, it's important to also understand that we can use this response criteria when we're thinking of progressive disease, and the idea that there needs to be at least a 25% increase in myeloma from its lowest point before we actually say somebody has progressive disease. And we'll talk a little bit more about this in a future slide, that particular concept. And now category 2 for 800, again, numbers and tests. 2 organizations that are there for you. I think it's important to really highlight our supports that are out there and available. We have Myeloma Canada, obviously. Those of you who are already on this call are familiar with Myeloma Canada and know that they are available through phone and email, as well as the International Myeloma Foundation. And this has a Canadian phone number option available to it as well. And these 2 organizations really want to be here to help people. They're available. Please reach out to them. You can reach out to them regarding educational material. Maybe you're newly diagnosed and you're trying to seek out a medical professional or academic institution or a myeloma specialist in your region. They actually have those connections. I have, on a number of occasions, been sent an email from the phone group that's saying, hey, we had this question. I'm wondering if you can help us out with this information. So they do reach out to the myeloma professionals and key opinion leaders, and I do encourage you to reach out to them for support, for help, for education. All right, so this is unfortunately, I might have to tweak my presentation, but it's not going to the main screen again, but that might save us a little time.
So I actually do have a question. So I guess I'll go back to the categories here. But I had a question with regards to, here we'll go back to the categories, but I had a question with regards to, I think it was this one, numbers and test results right here.
Okay.
With regards to MRD. So can you maybe just elaborate a little bit on MRD and what it is and if it's something that's standard in the US?
Okay, so MRD, or minimal residual disease, this is really trying to drill down into the bone marrow, getting at how many myeloma cells are still detectable, a very sensitive way of testing. And if a person has still detectable myeloma within their bloodstream, let's say that M spike is still present, the free light chains are still abnormal, there is no need to do MRD testing because we know that there's still myeloma present. But let's say somebody has been able to clear their blood completely of myeloma. There's nothing detectable. We look in the bone marrow and we don't see within that top layer of soil any monoclonal protein. That percentage of plasma cells within the bone marrow is less than 5%, and they are polyclonal, not single clone, but polyclonal, meaning they're healthy plasma cells. We can go even deeper into a more sensitive version of testing that is trying to see, is there any fine root to that weed that is still detectable? And I think the significance of looking at minimal residual disease is having to do with how long do we need to treat a person? And that's an unanswered question, I think, in the myeloma community. The idea of how long should a person be on, say, maintenance therapy? When can we stop treatment? And if a person still has active disease or detectable disease, we're less inclined to stop any type of treatment. It's probably not as relevant for looking at, do we change treatment or not? Because if a person has enough progressive disease, that it's not about minimal residual, it's about progressive disease that we would change treatment. But how long do we keep somebody on therapy? And one of the things that the International Myeloma Foundation has been working on is the Black Swan Research Initiative, trying to get a universal definition to what is called minimal residual disease. And so that starts at getting universal testing and having agreements on what type of testing. Everybody who uses that test knows how to use it. And so this has been a really, really important initiative by the International Myeloma Foundation and the International Myeloma Working Group. Dr. Shaji Kumar at Mayo Clinic, he has been instrumental in developing and getting that universal testing. I'm not sure if there's more that people want me to say on that, but it's probably more relevant into knowing when a person may or may not need to continue treatment.
Yeah, I think that definitely answers the question.
All right. So I think there we go. All right. Oh, it went back. I apologize. I think there's a sensitivity to the button. So we were getting into treatment and transplant, symptoms and side effects, and living well. And I'm happy to continue through, or if somebody wanted a specific category.
Let's go with transplant, since I have a question on transplant here.
Okay, so the first slide is not specific to transplant, but it will work our way through. And this is category 1, so that's not correct. There we go, category 3. And the answer is mites, MIBs, MABs, and others. The answer is, what are drug classes of myeloma therapies? And for many people, they get really quite confused on, you know, the generic name, the company name, what combinations they're on. And so I found this to be maybe a little easier way to categorize them. We have our immunomodulatory drugs, IMiD therapy, and these have been around since early 2000. Proteasome inhibitors with the ending in bortezomib, carfilzomib, ixazomib, that's where we get the MIB part of things. Monoclonal antibodies, these are relatively new on the landscape of myeloma therapy, including daratumumab, elotuzumab, and then one of the supportive care therapies, denosumab, which is used for bone strengthening. And then there's the others. And for many people, they're well too familiar with the steroid category, dexamethasone and prednisone. We also have alkylating agents that have been part of myeloma therapy since the 1960s. They've been well-established myeloma care, and anybody who's had a transplant know that melphalan is the drug of choice that we use at a high dose. There's some newer therapies and newer classes that are coming in. One of them is the SIGN, which some of you may be familiar with, as selinexor or XPOVIO, which is brand new in the last year. A number of therapies that are under clinical trials. And it's really about taking these drugs, using drugs from multiple categories with initial therapy. There's a lot of support for triple and maybe now even quad therapy using an immunomodulatory drug with a proteasome inhibitor, steroids, and then throwing on a monoclonal antibody. So the beauty of this is that we have so many different therapies now available in myeloma. And having been working in transplant with myeloma patients for almost 30 years, the last 15 years has been overwhelming, and the advances that we've made in the number of therapies, how well they work, and really how well they're tolerated. All right, category 3 question for $400. The answer is pieces of the puzzle. And I already started to allude to this with the idea of what are the components of managing myeloma. And we first start out with that initial diagnosis and initial therapy. And right now, sort of the accepted is using a triple combination, whether it be bortezomib, lenalidomide, and dex, or maybe carfilzomib instead of bortezomib. The addition of maybe a monoclonal antibody like daratumumab. But the initial therapy lasts for maybe 3 to 4 months. And at some point, we're looking at if a patient is eligible for transplant or is considered not to be a transplant candidate. Transplant is considered a consolidative type therapy where we're reinforcing that initial response, moving into maintenance. And then at some point, if there's relapse or progression of disease, that is another component to this overall landscape of myeloma therapy. Incorporated within all of that is this idea of supportive care, which is my particular love and focus, is wanting to make sure that people not only are being treated and getting disease control, but that we also have symptom control. We want to not only extend life, but promote quality of life. And so how do we get people to live well, live better while on these therapies, rather than having them have significant side effects that may compromise their quality of life or their ability to maintain on these therapies. So category 3, question for $600, and the answer is performance, preference, judgment, and trials. Sounds kind of ominous, but it really has to do with what is determining transplant eligibility. And this is where people may have some additional questions related to transplant. But when we think about looking at transplant eligibility, it's not just about age. We know that age can play a factor, but it's really not chronologic age. It's much more about physical or physiologic age. We need to do a full multi-system organ evaluation to determine if a person has good heart function, lung function, before we can move on. What is their performance status? Maybe they've got great heart function, but they are physically quite unable, and that would be concerning. We refer to these things as comorbid conditions. We need to take into consideration the psychosocial aspects, including the patient preference. Do they have good caregiver support? Can they take time away from work? If a person is participating in a clinical trial, that may preclude the decision to move on to transplant if it's part of a trial. We know that the patient's preference, the physician's judgment, clinical trial, what is the current data, and now in our current era of coronavirus, we are very carefully deciding who is moving on to a transplant right at the moment. For now, for those people that we would consider maybe more so on the elective side, if they're responding well to their initial therapy, we may not proceed directly to transplant right away at this time, although upfront transplant is considered to be the standard of care. And I imagine that we will revisit that in the future. We do know that upfront transplant has improvement in progression-free survival, but at this time, the data does not significantly show that there's improvement necessarily in overall survival if you do the transplant early versus late. We know that we need to have at least a minimum of 3 million stem cells or 2 million stem cells harvested in order to move ahead with the transplant. You will see a range anywhere from 2 to 5 million. At my institution, we prefer to get 3 million per transplant. Additional cells can be harvested that can be used for storage, and it may take a combination of efforts to get those stem cells secured. Neupogen, or filgrastim, also known as GCSF, can be combined with chemotherapy or another drug that is used for mobilizing stem cells from the bone marrow called plerixafor or Mosabil. And so there is an entire thinking process and multiple factors that go into determining when and if a transplant should occur. Were there other questions about transplant that people have?
Yeah, so I
think
have
of this
about
as
3 or
the
4 more questions when it
great.
comes to transplant. So the first question, since we're in this COVID pandemic right now, and some transplants are being delayed, so that means a lot of people are getting some more initial therapy, more induction therapy. So I mean, how can this, by people having, let's say, more than 4 months of initial therapy, how can this negatively affect them, for a future transplant?
That's an excellent question. And probably 10 years ago, I would have said maybe, or more so yes. But a few things have happened. One, we have therapies that are actually quite preserving of the stem cell production. Melphalan, or the alkylating agents, were much more harsh on the bone marrow environment, and people who had multiple cycles of melphalan-based treatment prior to transplant, we really did struggle with collecting enough stem cells. But no longer is that part of initial therapy. It's really more so with transplant, and then maybe later on in the relapse setting. The other thing that has developed in the last number of years is the use of this plerixafor or Mosabil drug. As I mentioned, this is part of the mobilization process. And what it does is it works in conjunction with the GCSF or the filgrastim. Filgrastim stimulates those stem cells to grow. But, for those of us who have some 20-year-olds who never really want to leave home, we want to get a way of getting those stem cells out of the bone marrow space into the peripheral blood, where they can be harvested through the apheresis process. And so Mosabil or plerixafor is that mechanism. It goes in and it binds to the bone marrow receptors that the stem cells would otherwise want to be adhered to. So it's basically shutting the door, forcing those stem cells to be out circulating in the bloodstream. And having been a part of the clinical trials that got plerixafor to market, I had seen patients that had actually undergone a couple of transplants already that were able to effectively mobilize enough stem cells to go on to another transplant with the use of Mosabil, even if they were unable to collect stem cells under other strategies. So I think also, and this is just me saying from an observation standpoint, I think depending on how long this COVID situation lasts and how many people defer transplant until a later date may give us some retrospective information as well. And I know that the doctors, all of these very amazing academics, are going to be looking at the cohorts of people that did defer transplant and do a retrospective analysis on what did that look like in the way of progression-free survival, overall survival. And it may play a part in how we decide to do things in the future.
Thanks, Teresa. So we'll move on to the next question. This one I'm pretty sure you've received in the past. So we collect stem cells, And are there not some myeloma cells that are part of those stem cells? So when you're giving back the stem cells, are you not giving myeloma cells back to a certain patient?
That is an excellent question, and you're right. I do get that question quite frequently, and I'll take it from a couple of different angles. One, at least at Mayo Clinic, and I know this can happen at other institutions, there is a blood test that is done called a peripheral blood labeling index, which is a measure of how many circulating plasma cells there are, not just these paraproteins, but how many of these monoclonal proteins are circulating. And for a sort of subvariant of myeloma, there's something called a plasma cell leukemia, where there's actually a large volume of these monoclonal proteins, these atypical plasma cells that are circulating, and we can measure those. And what that really does tell us is more about the biologic nature of that particular myeloma subtype. And what I mean by that is if somebody does have circulating plasma cells that are able to be classified, we know that that myeloma is a bad player. We do know that it is being more active and more aggressive. And so it tells us more about how the myeloma acts. There have been studies that have been done looking at people who have had circulating plasma cells and harvesting those stem cells with the idea that you could be harvesting myeloma cells. And what's important to understand is that myeloma, as I had said earlier, comes from plasma cells. And plasma cells are a subtype of what are called B lymphocytes. And B lymphocytes have a natural aging progression. It's not like a bacteria that if I take a bacteria and inject it into myself, I know I'll get an infection from that bacteria because it can reproduce and replicate. Where with myeloma, or more so these plasma cells, once it matures to the level of being a plasma cell, it has an end life. And so there isn't the concern so much about harvesting them and re-injecting them as there is the concern about how that subtype of myeloma is more active, more aggressive, and that's where the concern comes in.
Thank you. Our next question has to do with some of the side effects of high dose therapy as part of the transplant process. So some people report problems with sleep. Some people report problems with taste. And so what are strategies to perhaps have a faster and more restful sleep, and also on how to regaining taste?
Great questions. And the sleep one, I may defer until we get into our living well category because I do talk quite a bit about sleep and sleep hygiene there. But I will tell you that in the midst of transplant, taste change is very, very common. And when we think about how melphalan, or the high dose chemotherapy, affects the body, we know that fast growing cells are most greatly affected as a result of the toxicity of the chemotherapy. And that includes the hair follicles, which is why people lose their hair. It includes the lining of the mouth all the way through the GI tract. So people have mouth dryness and can even have mouth and throat sores. And that change that people are feeling and experiencing in their mouth is happening through the rest of their bowel, which is why so many people experience nausea. I think of mechanical nausea where the bowel is disrupted. And anybody who's had a transplant, they know that they're having a lot of diarrhea issues. And that's because of the sloughing of the bowel and the lack of the bowel to really absorb all of that fluid. We also know that the bone marrow is significantly affected, which is why we harvest the stem cells. Many people have a misunderstanding that the stem cells are treating their myeloma, but the reality is that the high dose chemotherapy that is treating the myeloma, it is the stem cells that are helping people to recover from the toxicity of the chemotherapy. And so once those stem cells get into their bone marrow space, They start to grow, just like if you plant a seed in the garden. You don't get a flower the next day you plant that seed. You have to wait for that growth. You need to wait for that bone marrow to repopulate. And it's during that time from when the full toxicity of the chemotherapy really hits someone, which is around day 5-ish, until those stem cells start to grow and reproduce enough, which is around day 14, that people are having these very significant side effects of the mouth and throat changes. And so my 3 helpful hints that I give to every one of my patients that I see is, 1, you have to stay well hydrated. It's like if you plant a seed in the garden, if you don't water it, it doesn't grow. If you don't give it nutrition, it's not going to grow. And so you need to hydrate, you need to get in protein-rich calories, and we need to keep people moving. We need to keep their body strong, and we need to reduce the risk of things like pneumonia and blood clots. And so those are the 3 things that I really encourage people is they have to hydrate. So eat, drink, and be merry, basically, is to hydrate, protein, and keep moving.
Fantastic. So I think we can go with 2 more questions before moving on to the next answer. So this one has to do with maintenance therapy after a stem cell transplant. Now, it's my understanding that some people, when it comes to maintenance therapy, with, for example, lenalidomide or Revlimid, some people will get that alone, or some people will sometimes get dexamethasone with it. Is there any particular reason for that? And who would receive both of those drugs during maintenance and who wouldn't, kind of thing?
Maintenance therapy is a really important question, and as you saw in one of the previous slides, it's one of the key components to the overall treatment paradigm of myeloma. Now, for each individual, that form of maintenance therapy should be individualized. As a whole, Revlimid or lenalidomide is very, very commonly used. Bortezomib may also be used, especially in those people who have what are thought to be a higher risk variant with cytogenetic changes that would put them in that higher risk category. Now, the addition of steroid is going to be even more individualized. I wouldn't say that that's typical, but it also may be necessary because we do know that steroids, dexamethasone, combined with some of these other therapies has what is thought to be a synergistic effect. And so it may be necessary if the response maybe to transplant wasn't as deep as one was hoping, that maybe they even get a combination of bortezomib, lenalidomide, and dex for a few cycles to have even further, deeper response. So that's going to be a little bit more individualized.
Okay, great. So for the last question for this section here, can you maybe just talk about how people with high risk characteristics in their disease, how the transplant process might be modified, for example, having a second transplant or
yeah. Sure. And there tends to be a little bit of controversy within the myeloma community, and I think some of that comes from a couple of different studies that showed a little difference in how somebody with a high risk disease variant, and when I talk about high risk, we're talking about cytogenetic changes by FISH studies, like a 17p deletion, translocations that are seen to be high risk, 1q amplification. And there was the Stamina trial out of UPenn that actually did a comparison of people who went through an autologous transplant and then were divided into 3 cohorts. One that went on to maintenance, one cohort that went on to consolidation therapy with Delegate, Revlimid, and dexamethasone, and followed by maintenance. And then a 3rd category that got the tandem or second planned transplant followed by maintenance. So everybody got maintenance. It was just a matter of if they interjected some consolidation in there or a second transplant. Now that study actually revealed that there was no added benefit to the consolidation or the tandem transplants compared to those who just got maintenance. And so that was really leading people to the idea that even people with high risk disease didn't necessarily have to have the tandem. But there have been other studies that have looked at, drilling down into some of the more high risk subtypes, and that tandem may be an important component for some people. So again, that's going to be very individualized.
Thank you, Teresa. Okay, so I think we could just move on to the next answer. And
Okay.
yeah.
And so this is the answer is observe or act. And what I'm looking at here is what is the time to initiate therapy at time of relapse? And so for many people, that is the burning, the concern that they have is, okay, I'm doing all of this, but what happens when I relapse? And in my support group, I'll tell you the first relapse that a person has is almost as devastating as their their initial diagnosis, because it's, people are moving along and they're feeling good and their responses as prescribed, and then the numbers start to change. And it's important to understand that there are different types of relapse. There is something called a biochemical relapse, meaning somebody is asymptomatic and they're having routine blood tests checked, and now we're starting to see those monoclonal proteins rise in the blood. And so for those people, we may just observe for a period of time, monitoring for true progression, like I said, that 25% or greater progression before moving on to changing therapy or initiating a new therapy, versus on the other end of the spectrum where you have somebody who is symptomatic. They have maybe new bone lesions or a new fracture or change in their kidney function, that there's a significant change, and then we're going to want to initiate therapy. There's a category kind of right in the middle, and it goes back to that idea of high risk disease, or that labeling index that I mentioned before, where we see right now that there's just biochemical progression. The numbers are rising, but maybe they're rising at a really rapid pace, or this is somebody that we know has had a myeloma that has been a bad player. And so we may want to, based on that individual, initiate therapy earlier than later to avoid that end organ damage, the CRAB criteria that we've been talking about. So each case is unique, and the treatment plan should be individualized. This jumped me right to category 4, which is symptoms and side effects. And I think this is an area that people will probably have a lot of interest in. Myeloma and treatment is the answer. And the question is, what are the sources of symptoms? When you think about it, sometimes the treatment can be just as challenging as the myeloma and have similar effects on the body. We know that myeloma, when it's not managed, we can have all that CRAB criteria, the elevation in calcium, the renal dysfunction, the low blood counts. Risk of infection is significant. When people have active myeloma, they're at greater risk of blood clots. We know that can affect the bones. There can even be a component of neuropathy just from the diagnosis. And for the majority of people, there's a significant element of fatigue. And you'll see in the side effect column that many of those symptoms are actually quite similar, that there's the risk of infection and neuropathy and fatigue. And ultimately, wherever the source of the symptoms are, it's all about how each individual is feeling. And important that we get all of these symptoms under control, one, to promote quality of life, as I mentioned before, and also to keep people on therapy. If a person is having significant neuropathy from bortezomib, we want to intervene on that early, because maybe they're having a great response to it. So we need to know, as healthcare professionals, we need to know early if you're having side effects to your treatment, so that we can make adjustments and keep you on that myeloma managing therapy.
So we do have a question with regards to side effects. I don't know if you want to answer this now or you want to go through the category before answering.
Let's see what the question is, and it might be in one of these categories.
Okay. Oh,
You go ahead
okay.
now.
You want to?
Yeah, you go ahead.
Yes. So I mean, there's a few questions, but so we talked about all those side effects such as neuropathy, um, and fatigue. So essentially, what can we do to help with neuropathy and fatigue and again, like we talked about a bit earlier, like sleep and
Sure.
the other part of the question are, are these are things like neuropathy, for example, uh, or damage to bones or muscles and joints, are these things reversible or are they permanent?
Great questions, and I think we'll be able to cover those in the next couple of slides.
Awesome.
All right, so atop your house or a feared viral disease. Now, before the current era, I made these slides, and the viral disease we're talking about here is not COVID-19. What we're referring to here are shingles. What are shingles? Now, this is a term that is used to refer to the varicella-zoster virus. This is the virus that people acquire when they have chickenpox, usually in childhood. And this virus remains dormant for most people within their system for a lifetime. And it has the ability to reactivate in the form of this skin rash. And it's a very specific skin rash that for many people, the way they describe it to me, they'll say, I feel like I got bit by a bug. I have a bug bite, a spider bite, and it starts out in one specific area with maybe some redness, like the picture shows here, little pustules or pimples that are fluid filled, and skin irritation. And what's happening is this virus has become active within a nerve tract, what we refer to as a dermatome. And you can see how on the picture that this is very localized, but it can be very, very painful. We know that people who have had chickenpox in the past are at risk, whether they're on any kind of treatment or not. But we also do know that certain treatments increase the risk of shingles developing. And so people who are receiving proteasome inhibitors, that class of drug that includes bortezomib, that includes carfilzomib and ixazomib, as well as the monoclonal antibodies, that they should be on antiviral therapy. Acyclovir, or valacyclovir are a couple of preventative measures. And there is a new vaccine that is approved in Canada called Shingrix. It is a non-live conjugated vaccine that is a 2-injection series given at least 2 months apart that can reduce your risk of shingles from activating. For the people who do develop shingles, whether it's because they weren't on preventative therapy or maybe they didn't need to be on preventative therapy and it developed, we would want to treat at higher doses of acyclovir or valacyclovir than what the preventative doses are. Wound management is really important because I have seen some of these lesions that are just ulcers that are very painful, and they can get a secondary skin infection if they're not well managed. And then because this is happening within a nerve tract, people may need pain management. Many of my patients refer to the nerve irritation that happens as zingers, where there be nothing for a while, and then all of a sudden it's like an electrical shock or a zinger that happens under the skin. It can be very painful, even just sensitive to light touch, like this person's hair could be touching it enough that would be painful to them. So shingles is something that we really want to mostly prevent because there's a lot of really good prevention for this. But if it does activate, we want to treat it from multiple angles. So we'll go on to $600 in the symptoms and side effect category. Bones, nerves, and procedures. And this will go into a little bit of what somebody was just asking is, what are sources of pain? Well, we know that pain compromises quality of life. And overall, I think pain is just there to let us know that there is something wrong. Like for instance, if somebody has myeloma bone disease and has a fracture, we know that that fracture causing pain is telling us that there's something wrong. Neuropathy can come from that herpetic neuralgia that we were just talking about in the previous screen, as well as peripheral neuropathy, which can be from diagnosis or even from treatment. Things like bortezomib can increase the risk of peripheral neuropathy. Many people will begin to experience neuropathy in their feet, in their fingers within the first 4 to 6 cycles after starting bortezomib. We know that we can reduce that risk of bortezomib-related neuropathy by giving it as a subcutaneous injection rather than as an IV, and I believe that most people have converted to this. We also know that those medical procedures, whether it be a blood draw or that bone marrow biopsy, can cause people pain. I think if you have one bone marrow biopsy in your lifetime, fine, do it unsedated. But we know that in the world of blood-based disorders, that people will have multiple bone marrow biopsies over their lifetime. I'm a big advocate for sedation. It means you don't get to eat before the procedure, but that's okay. For a short while to have the procedure sedated is so comforting for so many people. So I think preventing pain in any way that we possibly can, things like bone strengtheners to decrease the risk of fracture. We know that things like pamidronate, zoledronic acid, and denosumab can reduce the risk of bone fractures in myeloma patients. Let's do those preventative antiviral therapies and the sedation before procedures, whatever we can do to prevent pain. But when people do experience pain, I think we need to intervene. We know that pain can interfere with people's quality of life through sleep, through social interactions. It may be that you need medications like narcotics to help with your pain. Maybe pills versus a topical patch for some people will work. To prevent a fracture from happening, or if a fracture has happened, maybe there's a need for surgical intervention or radiation therapy. Believe it or not, activity can really improve people's sense of pain. It releases natural endorphins in the body, and so getting up and moving can be helpful for some sources of pain. How we treat it is really a matter of what is the source. We're going to have a different approach if it's neuropathic pain versus bone pain, or those nasty medical procedures that we inflict upon you. There are many people, and I think Canada, very generically as a whole, is very much interested in complementary and alternative therapies. So if you've ever noticed, medication and meditation are only one letter apart, and I don't think that's by accident. I think there are many ways that we can work towards managing pain and fatigue through complementary therapies. And I like to say complementary more than alternative, because I think both of these things, or all of these things, can work in conjunction. So I think it's important that if you are having pain that is not well controlled, or a new bone pain, that you do need to talk with your healthcare provider to see if there are ways that we can better manage that pain to improve your quality of life and improve your activity. So the last topic in this category, people have it, but they're not talking about it. And this can be a sensitive topic for some, because we're addressing things like fatigue, depression, and anxiety. You know, for the majority of people, they are experiencing fatigue and they're not talking with their healthcare provider about it. I'd like to think that probably close to 100% of us right now are experiencing some degree of anxiety over our global pandemic. And many of these things can lead to depression, or people can have a baseline depression diagnosis, and then having the diagnosis of myeloma can contribute to this. There's a lot of uncertainty that goes with it. Is the treatment working? Can I afford the treatment? Will I be able to go to work? Do I need a transplant? Will I be eligible for a transplant? So there are a lot of things that go through the mind. And I sometimes think about that old Pong game, where you start hitting the Pong ball, and the more you hit it, the faster it goes. And sometimes you just need to let out those concerns. You need to share those concerns with your support network. We need to work on how we can manage it, the symptoms that people are having. Part of it is talk with your healthcare providers about it. Sometimes medications can work. Exercise can really help with fatigue, with anxiety, getting proper rest, and we'll talk a little bit more about rest as a whole in another slide. Some of these complementary therapies. I am a huge fan of the psychological support that people get from community, and that community can be from support groups. I facilitate a group here in Rochester, and I missed my group in the last month because we were not able to convene. But on Saturday, we're going to be doing a virtual support group through Zoom, and I'm very excited to get reconnected with my group. I think prayer, meditation, spiritual support can be so helpful for people, whether it be myeloma or coronavirus that we're all concerned about. There are a lot of ways, a lot of angles that we can approach managing depression, anxiety, and fatigue. And it saddens me to know that people are dealing with this on their own without reaching out for support or getting the support that they need. I think the social network needs to be vast, because if you rely only on your caregiver to express your concerns, they get fatigue as well. Or if there's only one person you go to with all of your concerns, there can be fatigue for that recipient. And so it's important to have that social network that may even include a healthcare professional that is specialized in psychological counseling, a psychologist. So these are just my suggestions, and there's a lot of good documentation that shows that exercise can help with these things, and the support networks are so important. So that's the last slide within this specific category. And before I move on, I do want to ask if there are other questions about symptoms and side effects. We'll talk a little bit more about sleep in the living well category.
I think in the interest of time, we should probably move forward, because we did cover neuropathy and fatigue. I do have some questions that came in about bisphosphonates. I know that we already skipped that. We already did that category. So maybe at the end of the webinar we can go back to that. But right now, all I have is questions on bisphosphonates, and I have one more on transplant.
Okay, so let's go through these last few categories, and then we'll open it up to other things. So the answer is sheep can help with this. And so as you can imagine, we're going to be talking about sleep hygiene. Sleep hygiene is really important in the way of getting adequate sleep. We know that as a nation, and I assume that could translate into the Canadian nation as well, that we are a nation of sleep-deprived people. And part of that is our fast-paced society, but other things can affect how well or unwell we are sleeping. There are a lot of disruptions from TV to electronics, maybe having a lot of stress or anxiety in your life. And we need to think about strategies to improve our sleep. Things from getting into a specific routine. Let's say it's 9 o'clock and you shut off all the electronics and you put on your pajamas and brush your teeth, and your body sees these as signals that you are getting ready for sleep. It's a way of starting to calm your body and turn down the activity in your brain. I also think that deep breathing, relaxation breathing, cleanse breathing can help relax the body and relax the mind. Things to do that can be helpful, whether it be avoiding naps during the daytime, only sleeping in your bed so that you're associating your bed with sleep. So falling asleep on the couch may not be very productive for a good night's sleep. Caffeine and nicotine are not good for sleep. We know that alcohol may put you to sleep, but it doesn't help you to stay asleep, and it disrupts your REM sleep. So avoiding alcohol before bed is a good thing as well. Large meals can upset your stomach and cause nausea and acid reflux. So trying to avoid those things, getting into good habits and routines to try and reduce sleep disruption, turning off alarms on your phone or leaving all electronics out of your bedroom. Some people use noise machines so that they have white noise in the background so they're not disrupted by family members that may be getting up at different times. Or maybe you're a daytime sleeper because you work nights and needing to have that background noise to reduce the community noise outside your windows. So there are a variety of things that people can do, and I really want to stress how good sleep can promote healthy living in so many ways. It can reduce your anxiety level, promote your immune function, and overall promote healthy living. So in the interest of time, I'll just keep moving through these categories. So this applies to both patients and caregivers. I never want to forget my caregivers in the audience because they are vital to this whole process of getting somebody through the myeloma experience. So what is living well? Adopting a healthy lifestyle. And I want this all to apply to both our myeloma survivors and our caregivers. It's important that we manage stress. We need to maintain a healthy weight and a healthy lifestyle, and we need to do preventative care measures. You can see some of these pictures, which aren't showing social distancing right now, but we do want to, even though we are physically distant, we want to stay socially connected. Maybe not having your dog on your head like my golden retriever, but she is a sweet love. But having a pet can be a good way of reducing stress, living well. I have to take her for a walk a couple of times a day, and she makes me laugh every day. So there are a lot of things that we can do to manage our stress, from rest, relaxation, those social engagements, and again, those complementary therapies. We want to maintain a healthy weight. On this webinar, I am 130 pounds, but in person, maybe not so much. But we need to be really conscious of good nutrition, activity, and exercise. Being a slim weight does not necessarily mean a person has a healthy lifestyle. We need to really have a good balance of healthy living. We also need for people to do their preventative health screenings for things like blood pressure, cholesterol and lipid screening, thyroid monitoring. We need to do everything to prevent falls, injuries, and infections. Right now, everything that people are hearing about COVID protection or precautions is basically Transplant 101. Wash your hands, avoid touching your face, avoid crowds of people, and definitely avoid people that are ill. Wearing a mask if you have to go out and about, and report to your healthcare providers if you experience fever, respiratory symptoms, or any other symptoms of illness. And please, 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 if you are smoking, please do everything you can to reduce and eventually stop smoking, because that has a huge impact on so many aspects of health, from lung function to skin integrity to the risk of bladder cancer, a variety of things. So preventative health and healthy living for both caregiver and survivor. My final category is this. The reason we are here today doing this webinar. Many of you know Aldo Del Cal or know of him. He was the co-founder of Myeloma Canada. His mission was to educate and empower patients. He's had a passion and a dedication that has helped to grow Myeloma Canada to a national organization. And Myeloma Canada continues his work, continues his legacy, but unfortunately, Aldo left us last year. And I thank Aldo for his continued support in having me be a part of Myeloma Canada's mission, and thank him. And I want to thank the organizers today for having me be a part of today's webinar and the national meetings that have happened in the past and will happen in the future. I miss him, and I think there are many people who miss him, and I want to recognize him today for all that he has contributed to where we're at today with myeloma advocacy and support. So with that, we can answer some last questions if we have time, Gabrielle. I just want to remind people that right now is not the time to be out socially
physically connecting. We want to make sure that people are staying home and staying safe. But I'd be happy to answer any additional questions if we have time.
Yeah, we technically the webinar is over, but we can just finish off with 2-3 questions. This will be recorded, so for those that have to leave, then we could always catch the recording for the answers to these last few questions here. And so this one is going to be pretty quick, probably. We talked about the some of the side effects, and I think the answer to this will be a lot of what you already said. But what about dealing with weight gain? What can help with people undergoing treatment and who have found themselves to have put on some weight?
I think there are a lot of obvious reasons why people gain weight with the diagnosis of myeloma. I know that for many people, if they wanted to look at the glass half full side of a diagnosis of cancer, they'd say, hey, at least I'll lose weight. But the reality is they don't, because we first start you out on dexamethasone and high doses of this steroid that really puts you in a seafood diet. You seafood and you must eat it. It is a huge issue. And then if you have bone disease, fatigue, it is hard to get up and get moving. There is no easy answer to weight loss. And having been a person who struggled with this my entire life, it's really about being conscious. I think there are really 3 domains to weight loss and weight management, which is one, being completely aware of what you're eating and having good food choices. And that may even come down to calculating what your intake is. I have been a huge proponent and multiple times a member of Weight Watchers, a current member of Weight Watchers, and find that their approach is very helpful. But there are many ways that people can approach weight loss. I really think we're fooling ourselves if we think we can do it on our own. The second thing is about being mindful. I think we need to be mindful about why we're eating. Yes, if it's dexamethasone, that's a pretty obvious answer. But for many of us, we stress eat, we emotionally eat, and so we have to be truly mindful about it. The third thing is the activity. Now, activity will, unless you're running marathons, is not going to really give you weight loss. But if you are being conscious of what you're eating, fully aware of how much your intake is, activity will help you to manage your weight. Having 30 minutes of heart rate increasing activity is going to be good for your heart, for your mind, as well as helping you to maintain weight. But there is no magic pill, nothing easy about it.
Thank you, Teresa. So the next question has to do with bisphosphonates, such as zoledronic acid, for example. So these we kind of call them bone protectors. Can they fully restore or fully repair bone lesions?
The idea behind the bone strengthening agents, and bisphosphonates are the pamidronate and zoledronic acid, and then we also now have this monoclonal antibody Xgeva or denosumab. All of these are intended not necessarily to repair the bone damage that has already happened, but to prevent further bone damage and over time healing. But think about if you were out skiing and you broke your arm and you did an x-ray of that fracture, even 5 years later, when the bone had healed, you would still see the residual or the remnant of where that fracture had happened. You would see it as filled in cortical bone filling in to where that fracture was. So the bisphosphonates are really intended for prevention. They are also used for decreasing that blood calcium level when somebody has high calcium.
Thank you. Now for the next 2 questions have to do with transplant. So can transplant wipe out any immunity that you've had to, for example, your vaccines that you've done in the past? Can transplant wipe that out?
So at least theoretically, it's believed that people will lose their immunity to all of those childhood vaccines. And the Center for Disease Control in the US does recommend for post-transplant reimmunization. But I will tell you that one, not every institution, and I don't think it's universal in Canada either, that those immunizations take place. That's at the discretion of the physician. And I will also tell you that not everybody loses their immunity. For example, I have a young gentleman who has undergone a couple of transplants. He's even had an allo transplant, and he still remains having antibodies to the MMR, or the measles vaccine, that he had as a child. So it's not certain that you'll lose all those immunizations, but there is recommendation for post-transplant immunizations, but not live vaccines like the measles vaccine, which is why we had tested this young gentleman. Is we wanted to know if he had immunity or not. And a number of my patients have been tested and they still have immunity.
Thank you for that. So the this one we had talked about loss of taste or altered taste before. So I mean, I guess the answer was with time you'll get better and it'll get better. But is there anything else specifically that we can do to help with that to help regain taste a little bit faster?
That's really quite an issue during the transplant course, and really time is most of it, healing of that tissue. But if you can keep your mouth moist, that will also help, because the reason people have taste is saliva, and it's a lack of saliva production that decreases that taste sensation. It's also that lack of saliva and that dry environment that promotes dental cavities. I love, and if people haven't seen this, there is a beautiful webinar that was done right at the end of March on myeloma and oral health. I really encourage you to watch that webinar. It is one of the areas that I think over the years we have been really laxed from the medical community, and making sure that we're looking at is oral health. And part of that is, that wasn't the biggest fish to fry in the world of myeloma. We needed people to live before we needed to worry about their teeth. Well, people are living decades with myeloma, and so we need to be well-rounded in their health, and that includes dental health.
Okay. Thank you. So, I mean, that's it for the questions. Actually, we got one last one. So let's just do that one, and then we'll end off the webinar. So, a lot of times we hear that myeloma and its treatment, or its treatment specifically, can rarely cause secondary cancers. Are there any secondary cancers that are, I guess, more associated with the treatment of myeloma than others?
It's an excellent question. That there is the risk or the concern about secondary primary malignancies. And I think what's important to maybe tweeze out of this whole question is, we're looking at people who are already in their 60s, 69 being the median age. So people are already at risk of things like prostate cancer, breast cancer. If myeloma and myeloma treatment were not in the picture, would that breast cancer or prostate cancer have evolved anyhow? Likely, because as we age, all of these cancers are a possibility. But we do know that myeloma, which is a bone marrow disorder, and the treatment that is available, there can be the risk of a secondary bone marrow cancer called myelodysplastic syndrome, which is sort of a precursor bone marrow disorder that can evolve into an acute leukemia. And I have known a number of patients. Matter of fact, one of the co-founders of my support group, he also had this evolution from myeloma to a secondary MDS and acute leukemia. We know that this is a potential, but the reality is if myeloma goes untreated, there would be no concern for a secondary malignancy because the myeloma would take their life. And so it is one of those risks that we know is there, and we basically accept it, because if we don't treat the myeloma, there's a bigger risk involved. And so there's a small risk, and I think I've seen quotes of, you know, maybe 2% chance. I don't know what the current statistics are, but the risk of a secondary malignancy is much lower than the risk involved with an unmanaged myeloma.
Fantastic. Thank you, Teresa. And with that, the webinar is over. We went a bit over time, but I think it was worth it because we have all this this information that we were able to get from you, all this valuable information. So again, thank you, Teresa, for doing this for us. We look forward to you know, keeping you on the on the regular roster with us and doing future presentations. And wish you all the best and a great evening.
Thank you, and thank you all for attending and participating. Please stay home. Please stay safe.
Bye, everyone.